Now we're going to talk about the ischemic heart disease. So ischemic heart disease is, they say it's number one killer. At the time I made these slides, it was affecting more than 100,000, 5,000 people who were dying annually, right? So what is the risk factors for this? So the risk factors is certainly, right, cigarette smoking, high cholesterol, or essentially this could be secondary to diet, or it could be due to genetics, right? So high cholesterol, high blood pressure, right? Hypertension. And also if you have diabetes, right? So it could be type 1 or type 2 diabetes with insulin resistance. So all of these are risk factors to the coronary heart disease. The other risk factors is being male, right? Being obese, right? As you see here. Genetics, as I talked about. So if your family, right, has predisposition to cardiovascular disease. So let's say your grandfather had it, your mom and dad had it, your uncle had it, chances are you're also going to have it. So you could look back, right, in your family history. That's why when you go to the hospital, they ask, any of your family members, had heart issues. And if you can trace it back that, a lot of your family members had cardiac issues, you want to be cognizant of that. You want to be tested earlier, right? And certainly adjust modifiable risk factors, right? So what is modifiable risk factors? What is non-modifiable? So for example, I cannot change my sex. So men are more predisposed to cardiovascular disease than women, right? Can I change my weight? Yeah, I could exercise, right? So I can start eating a healthier diet. I can go to the gym to try to lose weight. Also, what about smoking, right? So is smoking modifiable? Yes, it is, because I can try to find a program which can assist with me quitting smoking, right? Some things are non-modifiable. So if you have a genetic disorder in your body that makes excessive cholesterol, right, you're going to have to take medications. If your body does not make insulin and you have type 1 diabetes, which is a risk factor, right? You can inject your insulin and follow, your prescription by the doctor, but there's nothing you can do to make your pancreas secrete more insulin. Same thing with hypertension. If you have genetic predisposition for hypertension, you cannot really modify it. Yes, you could take medications to help, control it, but you can't really modify it. So be cognizant of modifiable risk factors, that those you could adjust, and non-modifiable risk factors which you cannot adjust, right? The next thing we're going to talk about, right, is essentially what is this arteriosclerosis, right? So here you see actually the name atherosclerosis, and here you have arteriolosclerosis or arteriosclerosis. So what is the difference, right? So, and don't tell me the spelling. So what is the difference, right? So the difference is this. So when they talk about athero, right? Athero from the name plaque, right? So atherosclerosis is the position of plaque material on the vessel walls. So here we see, right? We were talking about the arteries, right? And we see the deposition of these fatty plaques, right? The lipid material. This is called atherosclerosis, from the word atheroma. And then we have arteriosclerosis, or sometimes you will see arteriolosclerosis. That's essentially hardening of the actual arterial wall. So they'll say thickening, right, of the inner wall, or sometimes you will hear hardening of the arterial wall. And these usually occur together. It's not like one and then the other. Usually you see a combination of these occurring. When they'll in a cadaver lab, right? If you ever get to go, they will sometimes cut into the aorta, and they will like press on it, and you'll hear like eggshells. If you're breaking eggshells, and they'll say it's friable plaque, right? So it means that the aorta and the actual aorta has so much deposition of plaque and hardening that it feels like almost like eggshells, and it's friable. You press on it, it's like breaking eggshells. That's how hard it becomes, right? So let's talk about what happens when you have the myocardial ischemia. So a person here is having chest pain, right? How does this occur? So in your artery, right, which is normally where the distribution of red blood cells, right, which is carrying oxygen occurring. If you have a lot of deposition of plaque and you have hardening of those vessels, now the lumen, right, becomes narrower. So before, right, if let's say this was moderate narrowing, right, goes from this to this, right, as you see, right, I have much less of a lumen for my blood flow to occur. So if there's much less of a lumen for my blood flow to occur, there's less blood supply that's now coming with my coronary arteries that are filling the heart. And what the person will experience, they will experience this ischemic pain, this pain that's coming on, right, on the heart. And you will see, right, most common, they will say radiates to the left shoulder, right? May also radiate to the neck, jaw, teeth, back, abdomen, and the right arm. So this is radiation. But the cause of this, the major cause of this, is your coronary arteries that we talked about, right? The right coronary artery and the left coronary artery. The lumen becomes narrow. It goes from this, right, to this as the position of plaque, right? Atheroma and arteriosclerosis become progressively worse over time. All right, less blood flow to the heart, and you'll have ischemic. Ischemic means lack of blood supply, blood flow through the heart, right? So you'll have myocardial ischemia. So when you ask a person, can you describe the pain for me in your medical assessment, right? Some of the things they will use to describe, they will say, oh, right, it feels vice-like, right? So you see vice-like constricting. They'll say it feels like a crushing pain, or it feels like an elephant is sitting on me, right? So these are the description of the pain that the person may tell you. So what you want to do is, when you're asking them to describe the pain, do not say, does the pain feel crushing? Does the pain feel sharp? Does the pain feel dull? Just ask them, can you please describe how you're feeling? So this way the person is able to tell in their own words, right? And this assessment, right, this assessment will be a subjective. Why is it subjective? Is because you cannot really measure it. It's subjective because it's the person telling you their symptoms. And some of the descriptive names can be vice-like, constricting, crushing, right, pressure, like an elephant sitting on them. And the other manifestations that you may see these patients develop, they may develop shortness of breath, right? They may have nausea, vomiting develop. They may have weakness, collapse, and coma, right? Secondary to not enough cardiac output, right, to the myocardium. All right, so this is what we see. Very common, right? Very common. They have this picture, right? They'll have a restaurant, right? Then they will have. Notice it looks like it's cold, right? So cold, right? And they'll show you, right, the radiation. So oftentimes, especially when there's big snowfall, right? And in the rural areas, the guys go out to clean their yards, their lawns. They'll have higher percentage of heart attacks. If you work in those areas, and after a snowfall, you'll have higher calls for a heart attack. So my question is, why do you suppose? Let's go back to this picture. Why do you suppose this classic picture has a picture of a restaurant, cold, and all of a sudden this guy is having, which looks like ischemic pain? Why do you suppose this is? You could take a guess.
You repeat the question?
Yeah. So my question is, oftentimes they show a classic picture. They'll show you a guy who is holding his chest. He's having ischemic chest pain, and often they'll picture restaurant, right? So it means like he came from the restaurant, he ate something, and then they'll show you cold, right? Like, I don't know if you could see, but it's like wind and cold. So my question is, why do they show this type of picture? What's so typical about it? Is everyone who goes to a restaurant is having a heart attack or chest pain?
No, he can be having reflux, gas free. Forgot the name.
You could tell me in plain terms. You tell me like
Yeah,
what do you think is
refuel
happening?
when you eat something and the acid go back, and that cause pain.
Okay, so it's not really the acid. So you kind of what you want to think about is the blood flow, right? So think about this. Let's say I went to the restaurant and I ate a big meal. Let's say I ate some steak, right? I ate some mashed potatoes or some other stuff. So I ate a big meal. Where do you think your blood flow is now at after I eat a big meal? Is the blood flow in the heart or the blood flow to the stomach in order to churn and digest?
The stomach, or the digestive system.
Exactly, right? So Alan says in the stomach, right? So yeah, Alan, you're correct. So the blood flow is now to the stomach to digest. And the other thing is, right, you noticed he is in the cold, right? When you go to the cold, what do you think your blood does? Not your blood. What do you think your peripheral vascular system does when you go and it's cold?
Constricts? Does
Yeah,
it
means it
constrict?
constricts because it wants to divert the blood flow to the essential organs, right? So that you sustain, right, the perfusion. So the reason why they show you this classic presentation is as follows. Let's say I went and I ate a big meal. So all the blood flow is now to the stomach, right? So less blood flow going to the heart. And then what else? Right? What else? I go outside. Right? And what happens is I have vasoconstriction. And now even more blood is diverted away from the heart. So now I have signs and symptoms of ischemia. And the signs of ischemia develop. Why? Because all the blood flow is now in the stomach and is diverted away, right, from the heart. So I'm developing this common signs and symptoms of, they call it angina, right? And very often you see they come in with after a heavy meal, right? After exertion, exposure to cold and smoking. And oftentimes why you see this after a heavy snowfall, right, is the guys will go get, they go get the shovel in order to plow the driveway, right? And let's say this guy is not in great shape. Let's say, he has arteriosclerosis and arteriosclerosis. He has hardening and plaque deposition, right? Maybe he was eating, right? And now all of a sudden there's a snowfall and he has to go clean the driveway, right? So that, he can be able to drive. And he starts plowing, he starts doing exertion, physical activity, and all of a sudden he starts to develop these characteristics, right, of angina, right? Pain and radiation to the left arm, jaw, right? So this is something you want to be familiar with, especially if you're working in those areas, in the rural areas after a snowfall, right? You may be called to patients who is having heart attacks, very common, right? For women, it's slightly different, right? So women may experience, they call it atypical symptoms, right? So oftentimes they may complain of fatigue, right? And they may have dyspnea on exertion, right? They'll have a decreased exercise tolerance. They may complain of this heartburn signs and symptoms, and they may complain of back pain. So women have atypical symptoms, and also diabetics have atypical symptoms. Diabetics may not complain of any pain. Diabetics may complain of GI distress, discomfort. They'll complain that they feel nauseous. They feel like they want to throw up. So the classic signs and symptoms, the one like I showed you here, right, may not always happen with diabetics and women, right? This is like your classic, right? Classic signs and symptoms, right? Which you want to experience, but just keep in mind that then they are not always seen in women and not always seen in diabetics. Women display things, right? Fatigue, dyspnea, back pain, heartburn signs and symptoms. So you want to be cognizant that they may still have a cardiovascular event going on, even though they're not specifically saying to you, "Oh, I'm having chest pain. It's radiating to the left arm." Right. So ischemia is essentially when you have when the demand, right, of the organs and the heart exceeds the supply, right? And I showed you, right, the narrower lumen, right? So this was the coronary artery. So let's say the lumen becomes narrower and narrower. So there's less blood flow through that lumen. So obviously, as you could see, right, the demand is the same or even more, and supply is less because now that red blood cell that's carrying oxygen there's not enough lumen there, right, to basically pass and supply the heart. So this we see the imbalance, right? Now, what happens in the actual myocardial infarction, right, is we have these vessel walls. So they're specifically referring to these coronary arteries, right? This is what we're referring to. So if you take a cross section of these coronary arteries and you look inside, right, you see, right, this deposition of this plaque, right, this fibrous cap, and this deposition of lipid, right? We said this atherosclerosis that was causing it, right? An event, right? An event can cause this, right, plaque to rupture, to have rupture occurring. And usually, to be honest with you, when they did the studies, the plaques that are rupture, they're usually not those chronic long-term plaques. They're usually more friable, and they don't have such a strong wall, right? They don't have such a strong fibrous cap, and those are the ones that are more prone to rupturing, right? And when this occurs, right, you have this vessel wall, right, that is now damaged. So now you have blood flow, right, into your lumen, right? So what do you think when you have a blood flow, right, the vessel that's ruptured, you and you have large lipids deposition that was here, and the integrity of the vessel, right, your artery. Remember we said, like, this is your artery, this is your normal artery, and let's say somebody got stabbed, right? They got stabbed with a knife, and all of a sudden they're bleeding, they're losing blood. Your normal tendency of your body is to come in and plug up this hole. Who does the plugging of this hole? Platelets, right? We talked about platelets. Platelets come, they rush to the site, and they start plugging up the hole. Yeah, and in the trauma, right, somebody got stabbed. I want that. I want the blood to essentially clot so that there's no more blood leaving. But what do you suppose happens in a coronary artery when this thrombus, all these platelets come in to try to plug up the hole? What do you think happens to this lumen? Do you think you have good blood flow or bad blood flow?
Bad blood flow.
Yeah, exactly, right? So if you have a thrombus that's now trying to plug up that hole, right, you have bad blood supply. Why? Because this thrombus is aggregating, right? It's coming and clumping and coming and clumping, so that you have fibrous deposition. So you have fibrinogen turning into fibrin, and prothrombin into thrombin to make that final, right, clot. And when this is occurring, less blood flow can go distally, right? So if less blood flow can go distally, right, we have essentially this formation here, right? So we have this, which you see here. So all the red blood cells that are here, they cannot go distally. They cannot supply their oxygen. They cannot take CO2. And the person is showing signs and symptoms of ischemic chest pain, right? He may complain of classical symptoms being chest pain, radiation to the left arm, jaw, right, that we talked about, right? And this is what essentially we see happen, right? This is shows you a cross-section of the whole artery, right? And this is the artery being here. And here, this is the normal. And here we see, right, all this plaque, regions of cholesterol crystals, right? All this deposition of the plaque, right? And this deposition of plaque is what's going to lead to vessel wall rupture and then thrombus formation, leading to a myocardial infarction. This slide shows you the deposition of all the fat, right? So when you have the atherosclerosis forming, how that low density lipoprotein, right, how these fat cells get deposited. So this could be secondary to your genetics, or it could be secondary to the diet you consume. So all those low density lipoproteins get deposited, and they form the atheroma, right? Atherosclerosis in your heart, right? So this is basically inflammation of the lumen, and this what's going to cause, right, this plaque deposition that you see here, and this is how it looks, right, on the vessel wall. So this is the fat deposit, right? And then due to an event, right? An event could be, right, you left in the cold doing strenuous activity, right? And all of a sudden this ruptures. And then the cascading effects of platelets aggregation is what causes, right, all the signs and symptoms that the guy in that picture is experiencing, right? So here, this is just a picture of the heart, right? We see the coronary artery right here, right? And we see this plaque, and we see this thrombus occluding the coronary. So it makes sense, right? If we said the way coronary arteries fill is during diastolic phase, right? Remember, let's say, let me just say, let's say this was your aorta, right? We said during diastole, your aortic valve was shut, so the blood flow can come, right? So the diastolic phase, blood flow is coming in, but all of a sudden, this guy has developed, right, rupture, right? And all the platelets are coming to plug up the hole. So if they're trying to plug up the hole here, yeah, you still have some blood flow up to the, proximal end, but do you think the blood flow distally is good? No, the blood flow distally is poor, right? Because the thrombus is not allowing the blood to go forward, right? It's not allowing it to proceed. So the person is developing ischemic chest pain, right? They'll say, I have chest pain, feels crushing, vice-like, radiating to the left side, right? Or it may be a typical presentation on the women and also your patients who have diabetes, right? But this is what actually occurs, right? This is just how the expansion of these foam cells, right, occur, right, up until the point they starts to bulge out, and then up until, right, the actual rupture, where the actual rupture occurs, and then you have plaque instability, right, and then all the cascading effects of platelets rushing in. So we talked about some of the risk factors, right? So hyperlipidemia or high cholesterol, right, secondary to genetics or your diet. We talked about hypertension. This could be also genetics and diet. Talked about cigarette smoking. This is your modifiable risk factors, right? So you can find programs where you could quit smoking. Talked about diabetes, which could be type 1, type 2, could be insulin dependent, where you were born with pancreas not making insulin, or it could be type 2 where you have insulin resistance, right? So either your pancreas is not making enough or your receptors are not functioning well. So all these risk factors will lead to deposition of, right, the lipid deposits, right, the foam deposits of cholesterol, causing atherosclerosis, and then hardening, right, hardening of the vessel walls through arteriosclerosis. And then an event can cause, right, basically this rupture, right, and cascading effects that occurring. And when we see these cascading effects is when we see, right, this ischemic symptoms developing, right? Right. So we talked about the platelets response. So what happens is they adhere to each other, so they stick with each other. They activate additional factors and they clump and they aggregate, right? So the whole purpose is that the body is thinking, well, the vessel wall is damaged. I got to plug up the hole, because if not, I'm going to lose all the blood and I'm going to die, right? So if I plug up the hole, no blood can leave, right? This is good, right? And that makes sense from a trauma perspective. But on the coronary artery, that actually all those reasons why we see all these signs and symptoms developing, right? Right, specifically what cells we're talking about platelets, right? The platelets are normally as they circulate in the blood, right, when the vessels walls are intact. But when the vessels walls are damaged and, right, they rush to that area, right, they form, right, deposits here, right? So you see plaque rupture and then platelet formation here. And this will not allow, right, the blood to go forward. So we talked about platelets, right? We see here, right, this is how it actually looks, right? This is red blood cells being caught, right, on these threads of fibrin, because as the platelets plug up the hole, the final pathway, right? I want to form a platelet plug. The platelet plug here you see is essentially would not allow red blood cells to escape and be in the vessel. And the final pathway is basically prothrombin, which is made in the liver. It's a clotting protein, turns into thrombin, and then the activation is fibrinogen, again clotting protein, into fibrin. And this is the fibrin clot. This is the final, right, fibrin clot that will basically make that final clot. This is what happens in all our vessels when there's damage to them, and this is normal body response to essentially save us from going into severe shock and dying by loss of blood. This is just a little bit zoomed up picture, but we see, right? So damage to the lumen of the vessel wall, right? And the vessel wall, sometimes they call tunic, right? So tunic, right? I don't know if you know, tunic is like a coat, right, that you wear. They'll say tunica intima, tunica media, and tunica adventitia or externa. So these are the walls of your vessels, right? Tunica intima is inside, media is the medial layer, and tunica adventitia or the external layer. So when you have rupture, right, and damage to that vessel wall, platelets are first to come. They clump up together, creating these cascading effects. And as more and more platelets plug up, they cause agglutination, right, and activation of these proteins that are found in your blood all the time, right? They're inactive, but when there is a damage to the vessel wall, right, prothrombin and fibrinogen, they activate in order to make a final deposit of the fibrin clot, right? And this will essentially cause, right, the final platelet plug. Right? So this is how it looks. Here we see some red blood cells that are caught in the threads of the fibrin. That makes sense, right? If these red blood cells are caught in the threads of fibrin, right, like as you see here, do you think they can go distally? No, they cannot, right? And if this happens to be a coronary artery and there's no red blood cells going forward, that just, you can understand why, right? That the heart will not get oxygen. It will not get O2 from the red blood cells because there is no circulation distally. So this is what essentially occurs, right? This is all of the stuff that I talked about, right, coming all together. You see the rupture, right? Platelets coming to plug up the hole, and this guy is, having total occlusion of the artery, right? He has total occlusion of the artery, and he has classic signs and symptoms of myocardial infarction, right? Chest pain, feels pressure-like radiating to the left arm, left jaw, right? Right, all the accompanying symptoms that he may have, such as increased respiratory rate, increased heart rate, diaphoresis, right, sweating. Why? Because of the response of the sympathetic nervous system. Because now body is, seeing that, right, it's on the fight or flight response, secondary to this insult. Right. So before we continue, any questions about, what actually occurs, right, when you have a myocardial infarction? What essentially occurs as a pathophysiology process?